Hey, my name is Karn and I am presenting on jersey finger. Jersey finger is the avulsion of the flexor digitorum profundus tendon from its insertion on the distal phalanx. It's also known as rugby finger. It's most commonly seen in football, rugby, and flag football. It's caused when the finger is forcibly extended during maximum contraction, which generally happens when the athlete is attempting to tackle and the finger slips on the jersey. Hence the name jersey finger. This injury has been reported to occur in all fingers, including the thumb, but it is seen in the ring finger in more than 75% of the cases. Signs and symptoms: the affected finger will be swollen and painful and will have a loss of active flexion to the DIP joint. And they may also have weakness in their grip strength. I found that there were 3 different types of classifications for jersey finger. Type 1 is the FDP tendon retracts all the way into the palm, and then with that is going to result in a loss of blood supply to that tendon. Type 2, it retracts back to the level of the PIP joint and it spares the long vernacular system, so it still has blood supply. And then type 3, the avulsion occurs with a fracture to the distal phalanx base, which usually results in a large bony fragment that gets held in place by the 4th annular pulley. So factors affecting the prognosis of treatment is the level at which it retracts, so what type of classification it is, and whether or not it has that blood supply remaining, and then how long it takes them to come report the injury. Because if they have type 1, they need to have surgical treatment within 7 to 10 days because it has that loss of blood supply, so that needs to get reattached as soon as possible. Type 2 and 3 do require surgery for the most part, but it's not as crucial that they get it right away because it still has that blood supply. And then following surgery, passive flexion exercises should be started early, and then active exercises should be started around 3 weeks after the splint is removed. The injuries that are diagnosed and treated early with the reinsertion of that tendon usually have good results, but they may end up lacking 10 to 15 degrees of that extension at that DIP joint, and grip strength normally returns back to its normal level as well. Any questions?